Okay. Hello. Thank you for this opportunity to talk. I'm not so happy to be talking not about 100 times that I was doing something nice, but sometime when something went wrong. This is challenging always. So just a brief introduction what is our hospital like and what we do there. So we cover the north part of Serbia, which is a region of approximately 1.9 million people. So our catch area is a little bit less because Belgrade is very, very close and some centers will be going towards that. More about organizational matters will be covered tomorrow in the lecture of my colleague, Dr. Anđelić. I will just fill you in with the details. We were actually prepared to do it in 2014, but we had administrative issues, so we started in 2016. So far we did 187 patients. Or procedures, actually, because we did 2 on 1 patient. And we have relatively good recognition scores, or MTQ-2B to 3, 73%. It could be better. We have relatively good clinical outcomes, but we have 22% mortality, which is, as we saw from earlier lectures, picture of the entire system, not just about our hospital. But basically, our average modified ranking scale after 90 days was 2.8, so that is not bad. About procedural complications, just a brief coverage. The most frequent complication was fragmentation, probably because we used a lot of aspiration thrombectomy approach first. We had not so many hemorrhage. Basically, in the population we covered, it was mostly non-significant. So I guess in these terms we are within the numbers. And we only had 2 vessel perforations, and basically this is kind of introduction to show you first case will be this perforation that we had a month ago, or a couple of days more. So this is a male patient, 67, with symptom onset 10 hours, and presented to EMC at 14:31, meaning 4.5 hours later, because his symptoms were fluctuating. So he's not sure what's going on. And he presented with mild right-sided hemiparesis, with paresis of facial nerve, dysarthria, and the estimated NHSS was 5 to 6. CT was unremarkable. There was some small chronic ischemia in pons, but CTA showed small defect, small thrombus on basilar artery bifurcation. That was occluding the left superior cerebral artery, and which was concluded. The tortuous vessel anatomy is shown here. You can see that we had basically very sharp angle in P1 segment, and the thrombus was actually lodged there. So this is a small defect that you can see. Sorry, just a second. Here I didn't. Sorry, I didn't find where is back. So this small indentation here is basically thrombus. So it's very small, but unfortunately a symptomatic one. We decided to go in. This is the equipment we used. At this point, I must say that 2 complications that I will show you were done sort of in the end before the next big equipment arrival. So basically, we were doing with what we had, and that's the limit of this. So our plan for this was to try to do Solumbra. We advanced the wire, we advanced the aspiration catheter, but at first the wire was within the left ACP. I'm not sure, can you see this? Maybe the lights could be switched on this part. If it's not visible, I'm not sure. If you see it, then okay. But while advancing the aspiration catheter, the wire removed from the ACP, and at that point we said, okay, well, we couldn't get in immediately. Well, let's just switch to try to do just aspiration, and we did that, and the result was not bad. I mean, we removed part of the clot. We liberated the superior cerebral artery, which was now patent. But as you see, we have a fragmentation and probable fragmentation and occlusion of ACP. So now we decided to go for another run and try to do Solumbra there. We were struggling to get the catheter, the wire within this segment. It was tricky, probably because of this angulation. And at one point, we realized that wire was starting to behave very strangely. This is frame by frame fragmented. Just yes. Yeah. Da, pa malo smanji. Could you dim the light a little bit, please? Okay. So, can I continue? Yes. So, the wire started moving not as we expected. At one point, we realized that the wire was probably not within the vessels. We then started, that's a moment that you freeze and you start thinking what happened. Is this perforation? We're not sure. And we started removing the wire, going back. And at that point, the microcatheter just jumped and breached further through this defect that we made. Apparently, wire perforation was initial event, but we had inadvertent microcatheter now perforation. So this is bigger damage and bigger hole. Yeah, but that it turned to be going on tip, so it was probably in the beginning, in the first moment when we did this, it was not J. Probably J was formed after the perforation, but we didn't realize that at that point.
Did you feel some resistance and thinking that was a clot or something like that?
No, we didn't realize that anything was going on at that point. We were blocked several times. So when we initially passed, of course, we're not used to this. We usually go smoothly, but we realized that we have tortuous anatomy, and we thought that we finally conquered the angle. So this was the effect of that. We didn't realize we saw the CTA, so we thought it's not outside. But when we realized that, additional damage happened just by this maneuver that sort of, when we were removing the wire, the microcatheter jumped. So there's a video here, but I'll skip it. You saw the effects, and because of the time. So after that, we gave contrast through microcatheter. We saw this collection of contrast. We saw extravasation. We gave contrast via the aspiration catheter. We saw this, so we realized, okay, this is definitely perforation. We had no doubt anymore. This is stagnating contrast on the native scan. And at this point, we were thinking what to do. We were thinking to do coiling, to try to do occlusion. But we realized from the CTA that posterior communicating artery was not patent, so main collateral pathway is not free. We're not sure what to do, waiting, and decided to wait for 15 minutes, then did another run. And fortunately for us, this run showed that there is no more extravasation, so the perforation closed. And of course, at that point, we said, okay, we're not sure what to do next. We couldn't get into the vessel that we want. We perforated. We had to give up. And we closed. Day after, this is a follow-up CT, we see this collection of contrast in the prepotent cistern, and going down, we see a little bit of mixing and also collections within the lateral ventricles. And there was not much ischemia, left thalamus. Of course, this is not good, but considering everything, this looked better than we hoped, because we were expecting left ACP stroke. But 2 days later, that follow-up CT showed stroke in the left ACP area. I will skip that and go to 10 days after. And this is the situation that we had 10 days after that. So this was May 13th, so it was 3.5 weeks ago. So we have the contrast is dissolved, the blood is mostly reabsorbed, and we have this ACP stroke and thalamic stroke. Not much in the brainstem, but this was not good. So patient was discharged these days with dysarthria, with discrete right-sided hemiparesis, with mild facial nerve paralysis, and his NHSS score was 8, modified Rankin scale 4. Okay, this is day 36. We know that there is potential for improvement. We hope that he will be better in days to come, but we'll see what future brings for him. And this is that part will be discussed, that it's not just about recognition and immediate care, but rehab after that. This is time that we have to use for these patients.
Can you make a pause here?
Yes.
Okay, a question for the panelists, for the audience. There is a perforation during thrombectomy. What do you do?
Run. Yeah, run away. Most of the times we do exactly what you did. We wait. And this didn't look like a disaster. I mean, there was obviously a leakage, but staying there, not really a big hole. I mean, then you had some sequelae, but most of the times if you wait a little bit, obviously it would be nice to have a balloon right there, but it's not the case in the ischemic stroke treatment. So the other option would be occlude the vessel, but not in the tip of the basilar.
Yeah, I'm afraid of this tortuous anatomy. Could we do anything with balloon? But never mind, we don't have the balloon, so it was not an option.
We do temporary placement of temporal coil and reducement of the blood pressure. So we place a coil in that segment where we have a perforation, but we don't detach it. And during the time we drop our anesthesiologists drop the systolic blood pressure to even more reduce the flow. So we wait, and then we do a run. Then we pull the coil out, and we see if there is still some extravasation or not. If we don't see it, we can further proceed or abort the procedure. And we also help with ourselves with Dyna CT and that time to see how big is the extravasation in that time, and we follow through the time we repeat the Dyna CT as well.
Thank you.
Well, in my hands, this patient would be dead. So I'm really surprised the way it went. But what do you think ruptured? I mean, what was the source of the bleeding? What did you rupture?
We suppose that actually we advanced into some little perforator, and that was where the wire was stuck, and we didn't know that, and we made this damage.
So it was the rupture of a small vessel?
Yeah.
Yeah. Probably, yes, otherwise it would have been different. But from the images of your wire, it looked like the wire was really going in many different directions there. Is that right?
Yeah, it sort of course, the reality is that patient moved, that our roadmap was removed. We knew that there was a lot of tortuosity in the vessels, this steep angle, so we were hoping it was right at the beginning, but further it went, we were, okay, what's going on? This doesn't look like we're in anymore.
And you are doing the procedure in general anesthesia or sedation?
This is in general anesthesia.
General.
But did you have any change of the parameters of the patient's
Nothing was reported to us with our anesthesia. Of course, when we stopped, this was the first questions we asked. Do you see anything? Is there any changes in the parameters? Is the vessel, is the blood pressure going up or down? What's going on? But they said nothing's going on right now.
And when you do control CT afterwards, did you from 1
Usually,
hour or
standard is 24 hours for most
but
procedures, but
it's
when we have complication, we usually do it earlier. We knew there was a perforation here, and we knew it was too early to see the stroke, so we didn't see the point. nothing that would alter further management. We did what we could. He was already behind hours of IV thrombectomy, thrombolysis. So basically, we supposed he was not a candidate for surgery. We didn't see much interest in additional information. But if that's a mistake, I'm ready to hear your suggestions.
Just because to assess the volume of blood which was in extravasation, so sometimes there is a need if you have breach in ventricular system to place EBD.
Yeah, but that's something that would take time to develop.
Yeah.
This is not so emergent. We knew that we will do it during the day, so I understand, yes.
And sorry, I missed the part. He was without or with IV therapy?
Without.
Without. So,
because of the timing, he was. They estimated that the time on arrival was already 4.5 hours or later, even though it's basilar. But he had also previous strokes. No, he had a lot of other contraindications. So the neurologist decided not to do it here.
So luckily, he didn't do the IV
Yes.
therapy.
Yes.
Yeah. So in a case that something like this repeat, there would have to be some kind of solution of hole or perforation to occlude it. Otherwise, it would not go like this. And luckily, like Dodi said, the patient also in our situation would be probably much worse.
We were thinking to do coiling. We were waiting. Of course, we're not happy to do it, but we're hoping that it will occlude. So, knowing from our experience with aneurysms, which is a lot larger numbers, we had this. We had actually patients that had perforation because we don't have dual biplane angiosuite, so we didn't realize the perforation because it was in the plane of behind
on the other side. Yeah.
So, but when we finished procedure, we realized that was a perforation and nothing happened, no blood, nothing. So we are like, you know, thanking God. But so we knew that we're not scared too much, but of course we're not happy with this.
Continue.
Okay. So second case. So this one is mine, I must say, so I take full responsibility for everything that happened here, but I hope you will understand the situation. It was 3 years ago. Male, 67, he was admitted 2.5 hours after the symptom onset, also posterior fossa, also vertebrobasilar circulation, stroke with these symptoms, and his initial NHSS was 13. Also having previous strokes, everything that we are basically used to. So it's always diabetes, hypertension, and previous strokes. And as you can see here, there were supratentorial strokes. There was also probably a new stroke in pons, but not too much of damage infratentorially. So we decided to, we saw this hyperdensity here, so we suspected that there was something going on mid-basilar, and CT angio showed this huge segmental occlusion of basilar artery. And we decided to go in. This was the equipment available at that moment. We did a run, and patient received IV TPA here, and we actually saw that it recanalized, but it was very, very thin. It was, you know, so sort of we wondered, will this hold? What will happen? I didn't. I was not happy to. I was suspecting that we have here stenosis with, of course, plaque that's wounded, and that will induce new thrombosis, and this was sort of, I was thinking, will this be enough? I decided to wait for a couple of minutes, then see what's on, and 7 minutes later we have another, again, this occlusion. So at that point I was not happy to say that I have to go in and try to solve this. What happened is that I opted for aspiration because we have a good experience with that, and I simply didn't want to go through this lesion and induce a new lesion of the plaque. I advanced wire, I advanced aspiration catheter, and after the initial run, I get some result. This looks better than the previous one because there's some of the thrombus is removed. At this point, I'm thinking, is there more thrombus or no, or is this just stenosis? As you can imagine, I was not prepared. We didn't have any special equipment for treating mid-basilar stenosis. You know that this is an area that it's not. There are no clear indications what to do here. It's still a matter of debate. So I decided to see. I thought that there is more thrombus here and that it's not safe, and wasn't happy with this. I wanted to try to remove some more. So this is one of the discussion. My internal discussions was I supposed to stop here? But I've proceeded. I advanced wire, advanced another aspiration run, and after this I get this. This slide here was supposed to show you that I placed the aspiration catheter below the lesion, but while removing the wire, it jumped and probably sort of kicked in the stenosis. So it reached up, and the position was not very stable, and I'm thinking that this could be something that made another lesion of the plaque and new thrombosis. At this point, I have to go on. I decided to go for a mechanical thrombectomy now, and so unfortunately, as you know, we're in a hurry, and I didn't save the image of the stent here, but trust me, it was an attempt of Solumbra. And 2 minutes later, I get this. So again, it was partially open with no ACP, and now it's closed. So I go for another run. I advance. I think here we'll see the position of the stent. No, on the next one we'll see it. And still, this is not complete result. I don't see ACP. And I decided to do another one. It was a solitaire X. You can see the markings, which was good. And I tried to open it within, to begin within the left ACP and then move down towards this lesion. But when it was opening, it slipped. So it opened beginning of the basilar tip and down. And also, again, when I tried to remove, when I removed it during the aspiration, again, the aspiration catheter moved up to the lesion. And so this is the slide that shows it. So it advanced again up here. And I get this. This is a very bad image, but because patient was moving and everything. But now I actually don't see the beginning of basilar artery anymore. I see left vertebral artery and pica. So one more time, I advanced the microcatheter and gave contrast to microcatheter. So this is what I see. Now I see the situation above. And I then gave contrast through aspiration catheter. I see the situation below. So again, we have this big segment that's occluded. And I do another Solumbra. But unfortunately, as you can see, everything is spaced. Still, again, I think that I didn't achieve position in the ACP. And in the end, on control DSA, this was the final result. So after 3 times of going with stent through this, I decided to give up. Realizing that this looks worse than when I started, but I just couldn't go anymore. I was risking something else. I didn't know what to do anymore. This was a case that it was easy for me to recall it because when preparing for this session, this was first on my mind. So
did you try to do a run from the anterior circulation to see the PCOMs?
No. I knew that they were not great from CTA. Of course, that would be wise to do here to see if they're enlarged and try to cover this.
Because it seems it's decompensated intracranial atherosclerotic stenosis.
Yeah, it looks like that. I didn't show the final outcome, CT 24 hours later. We see ischemia, something in the left ACP territory, something in thalami, something in right mesencephalon, and right and central ventral pons. So and of course left superior cerebral artery. So it's a lot of infarcts, and the patient actually didn't make it. 8 days later, he passed away. So
When you talk about stent, you mean stent retrieving?
Yes,
You,
yes,
you,
stent
you
retrieving,
pass
no,
with
no.
a solitaire?
Yes,
Because
we
we had quite a lot of cases like this, and eventually, after lots of unfortunate cases, I have the idea that in these cases it's definitely a stenosis. There's no no possibility. It's very unlikely that a thrombus forms there or goes up
course,
there and
of
stop
course.
in the middle of the basilar, to me. So our experience is that when you start aspirating and stent retrieving, every step is going worse than than the previous one. So now we would probably place a stent as soon as possible, as soon as we are convinced it's not a thrombus, but it's rather... There are probably some thrombi there, but basically it's a stenosis. So the sooner you stent, probably the better for the patient, even if it's not a low-risk procedure anyway.
I suspected that scenario, and I was trying to avoid getting in there. We, at that point, I think we only had like Enterprise or something, and nothing else of the options. We don't have balloon. We, in one case, used a balloon that's intended for peripheral infrapopliteal region. So we don't have special equipment for this. That is something that I would like to ask the panelists, who would do a PTA, who would do...
Yeah.
And what about, even showed me in previous years cases where he, for this kind of lesion, when it was opened, maybe just administered tirofiban or something in a small injection just to stabilize the plaque and try to keep it patent. So this is...
I can show it now,
yeah.
but then we can discuss. Maybe that's
Yeah,
also...
that was, I agree with Luca. We also saw, I believe as everybody, that whatever you do with manipulation, you just deteriorate and you spread that vulnerable plaque and that reaction to manipulation. And as well as Ivan said, is going to show, perhaps is the option to administer intraarterial tirofiban GP2 3B and then switch on the ICU to double anti-aggregation therapy because it's stenosis.
Yeah.
I would, and then some guys use coronary stents to place there, and technically it's an option. You have now low-profile coronary stents which could go there. But the question is that on the native CT you have already demarcation on the pontin region where the perforators are coming off the basilar artery from that stenosis. So the question is, what do you need to do all those gymnastics to get what?
Yeah, that's the case that we did the same thing. The mid-basilar occlusion, we passed one time with solitaire. It looks tight stenosis, not super tight, but tight. Then it occludes. And then what we did also previously in Toulouse, I think they showed, Christophe showed the cases when he opens the solitaire. And then, because the idea is, this is ICAD, of course, and then there's a rupture probably of the plaque, and then the thrombus forms at the site of the ruptured plaque. So the idea is, can we remove only the thrombus, and if it stabilizes the plaque, then we could probably do it without stenting. And this is the situation that we did in another pass, and then quickly administered 15 milliliters of tirofiban intraarterially with microcatheter just to cover this wall of the artery with the tirofiban with chemical, like we do, in the for example, tubes with heparin, to lower the risk, to lower the thrombogenicity of this part. It succeeded here and a couple of times later. So we leave it like this. and it stabilized the plaque. And we even didn't administrate later the IV to B3A, just stayed like this, the patient was fine. It worked more than a couple of times. Sometimes it doesn't work, you need to place a stent, but it's another, let's say, option, if you like.
If you place a stent, what double anti-aggregation therapy would you use, and when would you start to use it? Would you use tyrofibam as a bridging therapy and give bolus and then continue on the ICU and then there give a double anti-aggregation, or would you give it right in the angio through the nasogastric tube to start clopidogrel or Brilique? What would you do?
I must say I'm not a good to talk about it, because I do it almost like this every time and I avoid stenting, but for the panelists we can ask what is your regimen, Luca, or yours, if you place a stent, for example.
Yeah, unfortunately, we place more and more stent recently for ischemic stroke treatment in which you encounter stenosis. We go for Agrastat as soon as we deploy the stent and keep it by protocol, which means 12 hours or 18 hours, and then we switch to the double antiplatelets just before the end of the infusion, which means generally early in the morning the day after, more or less.
And which double antiplatelet? Yeah.
Aspirin and Plavix generally, because it's easier, or Ticlopidine, but I mean Plavix you can use the nasogastric tube, which is nice.
Yeah, just a small observation, because I work in Greece and we also used to have problems with having stents. And my experience is that in that particular case, when you have such a tight stenosis, you can practically put any stent you want. I mean, even an Enterprise or whatever soft it is, it's just going to create a very small lumen, and this is enough to keep the patient alive. So this is my experience when you don't have a balloon-mounted stent or something like that.
Do you have reocclusion even if you place a stent or not?
No. I mean,
settings?
I've done a couple of cases. I didn't have a balloon to do the dilatation. I just put the stent, I put the anti-aggregation, and miraculously, the stent stays open and the patient survives. So that's my experience. It's small experience.
Yeah, I agree. I think in most of these cases it's better to stent rather than... But I would like to know what people think. So raise your hand. Who would angioplasty and stent? Nagy. I'm sure you would. And No. I know you were not looking. And who? Hi, hello. How are you? And who would just go with medical therapy? And everybody else just doesn't know.
They would go home.
They would go home.
Who would think about the coronary stent?
Coronary stent all the time. They're very good. Now, so we started doing angioplasty stenting of these basilar artery stenosis 25, 30 years ago. And with coronary stents, which at the time were not as good as today. But today, they are fantastic. Of course, it's off-label, but this patient is going to die. So you have to decide, is it better that he dies or you do something? He will die anyway, maybe. But if you do something, most of the time it goes well. It's a beautiful treatment of basilar artery stenosis. I don't care if it's not approved because people will survive. In this case, case number 2, I didn't understand what age was the patient.
67 or 68.
67, because the brain didn't look like it. Looked like maybe 110.
Yeah, even yeah, but as you see, he had previous strokes. He was
Okay. Okay.
Okay, okay.
It was used brain, used.
He had a tough love.
He was a police officer. Yes, I'm joking. After reading about this, I would also do stenting with this knowledge. But as I said, this is sort of learning curve when to think that you're free to do this and try to do this. And I felt obligation to do something. I couldn't just.
Do you have a
No, I
cardiology
could-
in your place?
No, that's another problem. We are separated. They are in an institution that's like 10 minutes of driving. So it's not. We cannot just borrow
Yeah.
things.
Okay.
It's not. We can, but it's not that easy.
Ajay, please.
Good morning to everyone. I stopped using corner stand in the basilar artery more than a decade ago. Because of what? Especially the balloon mounted stand, you have no control the orifice of perforating artery. You are just undersizing it. The only control in your hand is sizing, oversizing, or undersizing. Especially this is problematic. Your angio system may not exactly measure the parent artery, especially if you have a stenosis, the elastic response of the distal part of the vessel may be create a problem because you are choosing the stent size according to the maximum parent artery. That's why I shifted my mind. I use corner stent. I think I am one of the first one who use corner stent. Dodi also in the brain. They are fantastic nowadays. I prefer to use the self-expandable stent. That is the strategy. Maybe not all of you are using it, but gateway balloon, if it is a little bit longer and wider, you can use that low profile stent in it without exchanging. But new technology is coming, and you are doing a balloon angioplasty and using the same catheter as deployment of the low profile stent. Most of the time I'm using Atlas stent to prevent reocclusion of the possible perforating artery. This kind of a technique still have some uncontrolled part of it, but this is what I am doing more than a decade.
But anyway, you would stand in the case.
For sure, yeah. If I have a dissection, my topic is in the dissection. But by doing angioplasty, we are creating dissection, so I certainly use stent.
There are two main problems in my mind with the Atlas stent. The first one is that you don't see it, which is fine in many cases. If you don't see it, that's perfect. You conclude it's perfect. But if you have to recross it, then you can make a disaster, because you don't see where you are crossing. If you are going through the struts, you just see the markers moving, but then it's too late.
Agree that this is not an optimum stent, and they didn't change at all the property of the stent. There is a Chinese company producing that kind of stent, maybe copied or not, I don't know. But they are visible, especially the new wire technology. I mean, the wire inside the other wire is giving us to see all part of the stent. Yeah, I agree with you.
Any more questions? Comments? Okay.